Director of Breast Cancer Resource Center, and we are delighted that you have chosen to spend your time with us today, and we hope that you will find this time well spent. We are so excited to partner with the Texas Comprehensive Cancer Control Program on this forum, and we are happy to offer continuing education credits for this event. BCRC is a 501c3 that has been providing breast cancer support and to Central Texans since 1995. And we are funded, of course, by our own fundraising efforts through grants and donations. And like all organizations, we have really evolved over the last many years. And currently, our mission services include patient navigation and support groups, education and outreach, and KEYS, Caring for Every Young Survivor program that is part of our CDC-funded grant, specifically for young women with breast cancer and young women with metastatic breast cancer. Now, many of you are already partners with us, and if anyone would be interested in learning more about BCRC, you can go to our website at bcrc.org. And finally, I would like to acknowledge the people that have worked so hard to bring this event to us today. Thank you to Molly McAdam, our grant specialist, Elaine Gonzalez, our community educator, Sharon Malatok, who is our chief program officer. And we are so grateful to Lauren Milius and Amanda Ibarra with the Texas Department of State Health Services and the Texas Comprehensive Cancer Control Program. Thank you for being here. And I'm going to hand it over now to my colleague, Lauren.
Thank you so much, Rayanne. As Rayanne said, my name is Lauren Milius, and I work with the Texas Comprehensive Cancer Control Program. And I'm just going to take a moment to go over our disclosure to learners, since we are offering continuing education today. So in order to receive continuing education, we need you to complete registration, attend the entire event, and complete the participant evaluation at the end. Next slide. So we do not have any conflict of interest to report. This is our non-endorsement statement. This is our off-label use statement. Like I said, in order to receive continuing education credits, you do have to complete an evaluation. So after today's event, I will send that evaluation via email to anybody who is not just registered, but has completed the entire event. And I'll just ask that you submit that back to me by the end of the day on Friday, August 27th. Next slide. And we have continuing education available for physicians, nurses, next slide, and all of the disciplines that you see on the screen. Next slide. I would like to acknowledge the CDC. The CDC funds both the Breast Cancer Resource Center and our program, and we thank them for their support. And I just want to tell you a little bit about our program. So we exist to design and implement impactful, strategic, and sustainable plans to prevent and control cancer. We are part of the CDC's National Comprehensive Cancer Control Program. We have two pillars. So one of them is implementing grant-funded projects across the cancer continuum. And the other is coordinating our state's cancer control coalition, which is called the Cancer Alliance of Texas. Many of you may be part of that coalition. If you're not, we invite you to participate. We'd love to have you. And as I said, we have projects across the cancer continuum. Our current focus areas are listed here. Through today's forum, we are providing education for healthcare professionals, which is one of our goals, to improve survivors' quality of life. Next slide. So thank you so much for being here. If you have any questions about our program, our coalition, or about the continuing education opportunities, I invite you to contact me at the email there. Like I said, I'll be in touch with everyone later today to provide you with the CEC evaluation. And at this point, I'm going to turn it back over to Rayanne, and she is going to introduce our first speakers for today.
Thank you very much. I just want to briefly go over the agenda. So our next step will be Dr. Jeff Stone, who will be addressing implicit bias in cancer patient care. Our next speaker after that will be Dr. Winifred Mack and Sarah Felderhoff, discussing fertility preservation in 2021 and the oncofertility navigator role. We'll take a brief break, about 5 minutes, and we'll all reconvene, and then we'll hear from Christine Janelle Adley, who will be talking about the survivor's perspective. And then we'll be talking with Dr. Bala, who will be discussing strategies to reduce implicit bias in cancer survivorship care. And we'll do a closing session after that with Q&A right before that. So thank you again for joining us today. I am so pleased to introduce our first speaker, our first presenter, Dr. Jeff Stone. Dr. Stone is a University of Arizona Distinguished Professor of Psychology in the School of Mind, Brain, and Behavior, and a professor of psychiatry in the College of Medicine. He is also appointed faculty in the marketing department of the Eller College of Management and a research associate in the Arizona Cancer Center, all at the University of Arizona. He directs 2 research labs in the psychology department at the University of Arizona. His research in the Self and Attitudes Lab develops new influence strategies to promote healthy behavior and the reduction of prejudice. In the Social Psychology of Sport Lab, his research investigates the causes and consequences of racial and gender stereotypes for the behavior of athletes, both on and off the field. Dr. Stone.
Well, thank you for the invitation to speak here today. I'm going to talk about a couple of things, although I think I'm probably only going to focus on the part 1 here. I want to talk about the psychology of implicit bias as it relates to cancer patient care. I want to make sure after you leave the session today that you have a very good understanding of both the verbal and nonverbal forms of implicit bias. I want to give you a sense of when does this happen and what does it really look like? And then I think I'll maybe touch on strategies for controlling implicit bias, although I think we have a presentation a little later about that. And I think we'll come back to that in the Q&A. I want to start with an example. When I talk about implicit bias, what am I talking about as an experimental social psychologist? And I want to tell you a story to illustrate this from a really great book called How Doctors Think by Jerome Groopman. It's a story about an error treating a patient relayed by Dr. Karen Delgado. So Jerome Groopman talks about a young man was brought into the ER of the hospital in the early morning hours. The police had found him sleeping on the steps of a local art museum. He was unshaven, his clothes dirty, and he was uncooperative, unwilling to rouse himself and respond with any clarity to the triage nurse's questions. Dr. Delgado was busy that night attending to other patients, so she eyeballed him and decided he could stay on a gurney in the corridor, another homeless hippie who would be given breakfast in the morning and return to the streets. Some hours later, she felt a nurse tugging on her sleeve. "I really want you to go back and examine that guy," the nurse said. Delgado was reluctant, but she had learned to respect an ER nurse who felt something was really wrong with a patient. His blood sugar was sky high, Delgado told me. The man was on the brink of a diabetic coma. He had fallen asleep near the art museum because he was weak and lethargic and unable to make it back to his apartment. Well, it turned out that he wasn't a vagrant, but a student, and his difficulties giving the police and the triage nurse information reflected the metabolic changes that typify out-of-control diabetes. So this is a classic example of how implicit bias can operate. It can operate when we're moving really fast. We look at people, we make a decision about who we think they are, and then make a decision about how to treat them that can lead to an error. In this case, an error that almost cost somebody their life. How does this happen? Well, we know from many decades of research in psychology that there's a particular process by which bias occurs generally. And it starts with how we categorize things in our social environment. We have a tendency, we're very, very good at looking at some new object, for example, and deciding that it has all the physical features of X. And the minute that we decide it belongs to group X, well, that's really beautiful and useful because now we know how to interact with whatever that object is. Turns out we do the exact same thing with people. When we meet somebody new, we will take into account their physical features. Sometimes we just may hear an accent with which they speak, and we'll decide they belong to a particular gender or racial or ethnic group, for example. Now, the minute that we think we know which group to assign them to, that can lead to the next step in the process, which is the activation of our stereotypes. The categorization brings to mind what is this group of people like. Stereotypes tend to range along 2 dimensions. They describe groups from warm to cold and from competent to incompetent. That kind of creates 4 quadrants. And of course, the groups that experience the most discrimination or health disparities tend to end up in the incompetent and cold category, or that quadrant of the kinds of beliefs people hold. And as I just implied, the minute we have information about what the group is like, what their attributes are like, well, that can lead to the behavioral component of intergroup bias, which is discrimination. Discrimination can be, extremely active and harmful. We're seeing examples of that in Afghanistan right now. But it can also be much more passive, but still harmful. And this is the kind of discrimination that we most associate with health disparities or disparities in care for cancer patients, where it's more like what we don't tell people or the time we don't spend with people that is sort of the manifestation of those biases and those stereotypes. And of course, we can't talk about stereotyping without talking about prejudice as well, because the minute we categorize somebody as a member of a group, that can also invoke our affective or sort of emotional reaction. And I can put hatred and I can put anger in that category there. But also disgust. We can also feel pity for certain groups. But we also have positive prejudices as well. We can feel a great deal of pride, especially if we perceive somebody as a member of our own group. And that can also lead to acts of discrimination. The important point about this process is that it can occur very consciously and very deliberately. And we all know people who, have their stereotypes. They're pretty sure that those stereotypes are accurate. They have no problem discriminating and they can talk about it all day. But that's not what we find in healthcare very generally. Most of the time, what we see is that this process occurs non-consciously or implicitly. And by that, what I mean is this process from categorization to activation of stereotypes or prejudices through to acts of discrimination in healthcare can occur so quickly that we don't even know they're happening. And that's what we're going to mostly focus on today, is that process. Now, how do we know that any of that is true? To give you a sense of that, what I'm going to introduce you to is the way that we measure people's implicit biases. I'm going to introduce you to what's called the implicit associations test. I find more and more when I do these workshops that more and more people have actually experienced an implicit associations test, but not everybody. What you're going to see is that this is a test that's designed to measure the strength of associations between concepts that we have stored in memory, sort of if this, then that kind of thinking. And it's based on the premise that associated concepts, things that we have associated in memory, are easier to categorize, easier to use in categorization than associations that are not very strongly stored in memory. Okay, now to do this, here's what I want you to do first. Sit yourself right now, position yourself if you're sitting or if you're standing, so that you can slap on either your left or your right knee or your left or your right thigh. Okay, I'll give you a second to position yourself for that. You can use the table that you're sitting at, but it tends to make a lot of noise. What I'm going to do is I'm going to show you some words one at a time on the screen. And what I'm going to ask you to do is categorize the words into one of two categories that'll be displayed at the top of the screen. And you do the categorization by either slapping your left or your right knee. Now, while we're doing this categorization task, I want you to be as quick but as accurate as possible. Can you hear the trade-off in that? And then I want you to do multiple blocks in training, not too long, but just enough to give you a sense of sort of what implicit bias can feel like. Okay, you ready? All right, here we go. We'll do the first training trial. So I'm going to show you a word in the middle of the screen. And if you associate the word with the concept of thin people, slap your left. If you associate the word with the concept of obese people, slap your right. Okay, ready? Begin. Okay, good. Got our first training trial out of the way. I can't hear anybody, so I can't comment on how you're doing. Let's try a second training trial. Now, this time, when I show you the word, if you associate it with the concept of good, left hand. If you associate it with the concept of bad, it'll be the right. You ready? Begin. Okay, good. All right, now I'm going to ask you to do our first test trial. This is going to be a little more complicated. This time when you see the word, if you associate it with the concept of thin people or the concept of good, it's the left hand. If you associate the word with the concept of obese people or the concept of bad, it's the right hand. Okay, ready? Begin. Okay, good. Let's do another training trial. This is just to take the handedness out of it. This time, when you see the word, if you associate it with obese people, it'll be the left hand. And if you associate the word with thin people, it'll be the right hand. Ready? Begin. Okay, great. All right, let's do another test trial. And this time, this is going to be that complicated version that we did a minute ago. But this time, when you see the word, if you associate it with the concept of obese people or the concept of good, it's the left hand. And if you associate the word with the concept of thin people or the concept of bad, it'll be the right hand. Ready? Begin. Hang in there. All right, very good. Well, let me explain to you why we would say this is a good measure of anything in psychology. So what happens with this test is that in the first trial or phase, we do something very simple. We're just categorizing using one category, obese versus thin, and then we do good versus bad. This is fairly simple, and you probably found that it wasn't too difficult to keep up with the pace at which we were moving. But then in the third phase, we do our first test trial, and this is what we call simultaneous categorization. And it's designed to be what we would call stereotype congruent. It's based on the assumption that what we're all walking around with, stored in memory, is a strong association between thin and good and obese and bad. And because those are the stored associations that we have in memory, when I ask you to use words and do a categorization task based on those associations, it's fairly easy to do. Right? You can kind of keep up with the speed with which we're moving and you're not making as many mistakes. If we were in a room together, what you'd hear is that you would all sound like a marching band, which is working outside my office right now. You'd all be in unison and you'd all be pretty much right on task together. Then what we do is we, as I said, take the handedness out of it by just reversing something that you did before. And again, that's fairly easy to do, even though you're using the hands differently. But then we do that last test trial, which is also simultaneous categorization, but this one is designed to be stereotype incongruent. And it's based on the assumption that what you're not walking around with stored in memory is a strong association between thin and bad and obese and good. And because that isn't what you have stored in memory, when I ask you to do the exact same task you did before using the same words, it's more difficult. And you could probably feel for yourself that you were struggling to keep up with the pace when we did the stereotype incongruent trial compared to the congruent trial. If we were in a room together, what you'd hear is that it's more like a Latin percussion ensemble where everybody'd be doing it at a different rate because everybody would be essentially struggling, right? And that's why it's designed that way. The measure of implicit bias using the IAT is that we find when we do this on a computer and we're measuring how quickly people are making those associations, we get a slower reaction time. People are slower to do the incongruent trials compared to the congruent trials. And then we just can compute a difference score from the difference in those reaction times. Typically what you see in the literature, and I'll show you an example in a minute, is that positive scores indicate higher implicit bias on this test. And I'll just say this real quick because I always get a lot of questions about this, but a lot of people always wonder, well, you know, what if you did the incongruent first? Or what if instead of words you used faces, or with the obesity version, you can use silhouettes of thin and obese people? And the answer is lots of studies have been done manipulating the order, manipulating the stimuli, and it doesn't seem to matter very much at all with respect to how much implicit bias we measure. And I think there's a good reason for why that's true. If we're right about our assumptions, about what's stored in memory, what associations are there, as long as we make people think about those associations, either through words or faces, for example, they still struggle with the incongruent trials because that's the information that's not stored in memory. And I apologize, I can't see the Q&A, so I think I can see the chat. So I would say if you have a question, put it in the chat for me. This is just a small example of all the studies that have now been published on implicit bias in healthcare. And I wanted to point out that if you did struggle on the incongruent trials during this little practice that we did, don't feel like you're alone because most people do. I took that example right from this paper by Sabin that was published in 2012 on implicit bias towards obese people. And what's interesting about that study is they were able to recruit 2,200, almost 2,300 physicians, national sample of physicians. And they found that the physicians showed just as high of implicit bias towards obese people as non-physicians did. The total sample in this study is 350,000 subjects. So it's a huge sample size. So obesity is one of those categorizations that most people have strong associations with. But plenty of studies that have been done now looking at implicit bias towards Blacks, towards Hispanics. Some studies that have been now done looking at specific patient groups. So for example, nurses and doctors in a drug and alcohol clinic and their implicit bias towards injecting drug users. And then the final three I wanted to show you are the published studies on implicit bias having to do with cancer patients. Penner in 2016 with Black cancer patients. And then two that are more recent, looking at specific groups of cancer patients, such as women with lung cancer versus lung versus breast cancer. And then a study we published in 2019 showing implicit bias towards women with cervical cancer compared to ovarian cancer as a comparison group. And that was among gynecologic oncology providers. So plenty of evidence these days that implicit bias is harboring itself in the minds of providers. And it seems to be across different areas of healthcare for sure. Oop. Okay. So the bias is there. That's what the general consensus is. Next question is, of course, does it matter? How does it affect patient care? And in some reviews that have been done, including one that my colleagues and I published recently, when we look at all the evidence for how implicit bias relates to behavior in a clinical context, there's a very clear signal. And that is what I'm about to talk about with respect to communicating with patients and when we interact directly with patients. Let me walk you through sort of the theory behind what we see in these studies. So what we know from a lot of studies to this point is that anytime people interact across group boundaries, that's kind of the general sense. But when we're talking about providers interacting with diverse patients, there's always a degree of explicit bias operating, and there's always a degree of implicit bias operating. And when it comes to explicit bias, what we know from 4 or 5 studies at least now, is that it's pretty low among providers. Most providers just don't say that they don't like certain patient groups in an explicit, conscious way. In fact, if anything, what we find is they have very, very strong egalitarian goals. They have very, very strong commitments to providing, equitable care to everyone. And so when you think about how they achieve that goal, that low bias goal, one of the ways that people would do that if they're going to interact with somebody from a group who's different than theirs, so a provider interacting with a minority patient, for example, they might do that through really thinking about what they're going to say. If they really wanted that patient to leave that meeting feeling like, hey, that was a really good meeting, that was really fair, I got the best care I could, how would you accomplish that? And you might do that by thinking, well, there's certain things I want to say and I want to make sure I say them. And so the degree to which we're trying to be fair influences the content of what we say. Now, what's interesting about that is that if I asked you afterwards, how did that meeting with that patient go? you might think, well, let's see, I wanted to say certain things. I wanted to talk about certain things with the patient. I did that. I think it went pretty well. And so what that implies is that to the degree to which we're trying to be fair and equitable during an interaction with a patient affects what we say, and then that subsequently affects how we think the interaction went with the patient. Now, as I said, at the same time, there's also a role for implicit bias going on. And one of the things that implicit bias does, I think, when I think about kind of fundamentally what it is, it's really our gut reactions to things. It's our quick, non-conscious gut reactions to things. Now, if we like something, our gut tells us to move toward it, right? We go forward into it and we engage with it. But if our gut is telling us that we don't like something, right? Something's not positive for us, it's negative. Well, then we move away, right? And we turn away and we put barriers up. And so you can see what's happening is that implicit bias is affecting the physical side of communication, or what we think of as the nonverbal side. And so to the degree there's implicit bias operating when we interact with patients, it's most likely to affect the nonverbal channel, or how we're talking to the patient. Now, what's important about that is that if you ask a patient afterwards, how did that meeting go with the physician, right? Well, the patient's sitting there and they may be hearing that you're saying all the right things, right? The content of what you're saying is very, very helpful. But the way in which you're saying it seems like you're not very interested in what you're doing. Or maybe you're actually even, turned off by what you're doing. And so there's this inconsistency between the verbal channel and the nonverbal channel. And that inconsistency seems weird, right? And what ends up happening is, to the degree there's implicit bias and it's affecting how we're talking to someone, they're getting that inconsistency and it's making it seem like a weird interaction. And they end up walking away saying, I didn't like that physician. I'm not satisfied. I don't trust that person. I'm not going to recommend that physician to anyone I know, right? So essentially the implicit bias affects the patient's perception of the interaction. So that's the theory. And there's been a number of studies done in laboratories as well as in clinics showing this process taking place, and how the explicit bias and the implicit bias can do two different things at the same time. When you think about what that looks like, what those negative clinical behaviors are that correspond with high implicit bias, this is a list of some of the things that come out of the research. And so, it really starts off with, how do you greet the patient? Do you use their name? Do you introduce yourself, or you just jump right in? And then what's the physical arrangement? Are you standing above, towering over the patient, or are you equal status seating, for example? Posture is a big one. As I said, implicit bias makes it sort of move away from things. And so are we sitting back? Are we, creating distance through that? Putting barriers between us and the patient, as you see in this picture on the top, the laptop, the chart, putting all that in front of us so that there's something between us and the patient. Those things tend to inhibit communication, right? Facial expressions, frowning. You could be saying all the right things, but if you're frowning while you're doing it, you're giving that inconsistent information, right? And then talking too much, interrupting. We find in some of the research we do, an inappropriate level of questioning of the patient corresponds with implicit bias. Being too technical in your language is another correlate of implicit bias. And then what's interesting in some of the research we've done recently is finding that the closing tends to be really awkward and abrupt when there's higher implicit bias. Physicians don't summarize, they don't talk about next steps. They just sort of leave, and that ends up corresponding high with implicit bias. And I think what's interesting about that is you may be doing everything right during the entire meeting with the patient, and then you forget the end. And what's the last thing they remember as they're filling out their patient satisfaction survey? They remember that closing. So there's a lot of interesting implications for that. When you think about, what can you do to take control of this process? What I like to focus on are all the positive behaviors that come with lower bias. And so, some of which is illustrated nicely in these pictures, but, leaning into the patient, equal status seating, close proximity, don't sit across the room from them, facilitating gestures, smiling is one. And then, paying attention to how you greet and also close at the end of that meeting. So I think nonverbal expressions are one of the ones that we really need to pay attention to and really need to sort of think about, how do we work on those? Okay, I'll just end here by saying something really quickly about, when it comes to taking charge of implicit bias. The research generally shows that it's hard to change those associations that people have learned over the course of their lifetime, or in some research that we've done, the culture of medicine has its own biases that get taught in medical school, for example, or in training for nursing. And so people learn these associations and they become very, available to them in an automatic way. And that process that we talked about originally, from categorization to activation to behavior, becomes very routinized, very automatic. What I think I focus on with respect to helping people understand how to reduce implicit bias in healthcare is really the idea that we can control this. And there's good reasons why you need to categorize people based on race and ethnicity and religion and culture. I mean, all of those things can actually facilitate healthcare. So it's not so much that we don't want to think categorically, it's that we need to be careful what we do with that information. And that's why I like the idea of focusing on controlling what you're doing with the information that you have about people. And so what I like to focus on is activating these control strategies. I don't have time to go into detail about all of them and the ways in which you can use them, but we can come back to them maybe at the end of the presentation.
Thank you so much, Dr. Stone. That was really informative. So our next speaker, I'm so excited to tell you about, is Dr. Winifred Mack. And Dr. Mack is a board-certified reproductive endocrinologist and infertility specialist in UT Health Austin's Cancer Fertility Preservation Care Team. She specializes in understanding oocyte and early embryo biology to help patients facing infertility issues and recurrent pregnancy loss. Additionally, Dr. Mack is an associate professor in the Dell Medical School Department of Women's Health. And Dr. Mack earned her medical degree from the United Medical and Dental School of Guy's and St. Thomas Hospitals. She completed a residency in obstetrics and gynecology and at Cedars-Sinai Medical Center, and a fellowship in reproductive endocrinology and infertility at the University of Pennsylvania. Dr. Mack has authored and co-authored several publications ranging from the cost-effectiveness of pre-implantation genetic screening for women 37 years of age and older undergoing IVF to polycystic ovarian syndrome and the risk of cardiovascular disease and thrombosis. Dr. Mack is unfortunately unable to be with us today. However, she has so graciously recorded her presentation for us, and we will play that for you now.
Well, I'd like to thank the organizers for inviting me to speak about fertility preservation. I'm Dr. Winifred Mack, and I'm an associate professor at the Dell Medical School. And I am actively involved in our fertility preservation program at Dell Medical School. So I'd like I was asked to talk about fertility preservation. And in this talk, I will talk about the new developments in fertility preservation, but I also want to really discuss some of the barriers that may be hindering patients' access to fertility preservation. So I hope you enjoy the talk. So this is just one slide to tell everyone why it's so important to give women information about and young girls about fertility preservation. And this slide shows basically that women are born with a finite number of eggs. And so here we have on the this axis the number of germ cells, and on this axis we have the age before birth, so prenatal and sort of reproductive lifespan. And these authors, they looked at the number of germ cells throughout sort of pre-birth, throughout reproductive lifespan. And what they found was that before birth, there is an increase in number of germ cells or oocytes, which peak in mid-gestation. And then really shortly before birth, there is a attrition of a significant number of germ cells. So really at birth, young baby girls will have 1 to 2 million oocytes. And this process of attrition of oocytes is a continuous process. And so really by puberty, which is around here, you're left, a young girl is left with 300,000 to 500,000. And as she goes through reproductive life, she is continuing losing oocytes. And really by 37, where we're about here, you have about 25,000. And then by menopause, you have about 1,000 oocytes. So anything that will disturb this, i.e. accelerate this attrition, such as chemotherapy, radiation, potentially could leave young women with less oocytes in their lifespan. So really, fertility preservation is one, trying to prevent, sort of capture the oocytes, get oocytes before exposure to chemotherapy or radiation, as really, you can see that really women cannot make new oocytes during their lifespan. So it's really important that we offer young girls and women an opportunity to save some of her oocytes potentially for future fertility. Okay, so so that's sort of an overview of why we should be offering fertility preservation. And another reason why is that this really nice study done at UCSF, they looked at, they performed a retrospective survey of over 1,000 women from a cancer registry using standardized questionnaire for regret and quality of life, and looked at sort of, was there a difference if they had pre-treatment infertility counseling by a fertility specialist with their oncologist or by the oncologist alone? And what they found was that if the women had pre-treatment infertility counseling by both a fertility specialist and oncologist, they had a significantly lower likelihood of regret than if they were just counseled by their oncologist alone. And you can see here the score. This is a score for the regret. It's a standardized regret questionnaire scoring. And you can see this is if they saw the fertility and oncologist together, it was lower, significantly lower than if they just saw the oncologist. And also what they also looked at is if they actually went through fertility preservation, they also had lower regret scores than if they just had counseling with the oncologist alone. So here we are, if they actually went through fertility preservation, they had even lower regret scores than if they were just seen by their oncologist. And so this really gives us information, and also they showed differences in quality of life. So this is another reason for offering counseling to patients. And it may be that it should be a multidisciplinary discussion involving a fertility specialist as well as their oncologist, because it could mean that they have a improved sort of sense of less regret, and so the counseling may be more efficacious if a fertility specialist is involved. And then sort of looking at it from a different perspective of why maybe why oncologists are hesitant to talk about fertility preservation. There's this another nice study from France. I couldn't really find an American study. So they looked at sort of fertility preservation in women, and really sort of, this was a national study about French oncologists' awareness and experience and feelings about talking about fertility preservation. And you can see here, they sent the survey to over 1,000, and they got about 102 responses, and this is the year that it was done. And so I'd like to point out that these were some of the important things that they presented in their results. So one question was, how often do you discuss infertility risk resulting from cancer treatment? And only about 47% really sort of discussed it with their sort of 76 to 100% of the time did they discuss infertility risks from cancer treatment. And another question was, how often do you discuss fertility preservation before beginning treatment? And you can see here that only 37% discussed fertility preservation before beginning in the treatment, 76 to 100% of the time. And how often do you refer your patient to a fertility center before beginning treatment? And really only 22% really consistently, 76 to 100% of the time actually referred their patient. And then how often do you refer your patient to a fertility center after treatment? An even lower number of oncologists consistently referred, and most of them didn't really. This is 1 to 10% of the time they would refer to fertility center. So from this cohort, you can really tell that there are some barriers from the oncologist point of view. So then I want to talk about sort of from the patient perspective and sort of more process perspective, what are the factors that hinder decision-making for women with cancer and contemplating preservation treatment? What are the other barriers apart from hesitancy of the oncologist to refer on? So this was a really nice look at sort of what potential barriers. And so I'm going to draw your attention to, so this is women with cancer referred to oncology services. They are seen at their oncology consultation. They're provided information about cancer treatment, fertility. Then they get referred to fertility services, and then they have at their fertility consultation that they are offered different fertility options, and then this is a decision to proceed with fertility preservation. So this group looked at sort of what are the barriers within the oncology service and within the fertility services. So external barriers, as we talked about, is lack of information provision, timing of information provision, and patient-provider communication. So as you saw from the French study, there is some barriers of oncology providers potentially providing that information because maybe they don't have the expertise. Other external barriers, which are to prevent fertility services, is the personal situation of the patient. Hormone positive cancer, fertility preservation is not a priority. Transition issues between services. And so these are the external barriers, and internal barriers are really sort of patient specific. And then on the fertility services side, what are the external barriers? Also lack of information provision, timing of information provision, patient provider communication is also sometimes a barrier on the fertility side of things. And then a major barrier, I would say, is the financial concerns of the actual cost of fertility preservation. All right, so a colleague of mine looked at medical egg freezing and how cost and lack of insurance cover actually impacts women and their families. This is quite perceived as maybe a major barrier. And so what they looked at was really sort of the US and what reasons patients gave for or for how to fund their egg freezing before cancer treatment. And in Israel, where it's totally free and it's paid for, and you can see here, number of women utilizing, this is percentage. And so there's many different ways in the US that patients pay for their fertility preservation. And you can see that it could be sort of a lot of 45% said IVF clinic compassionate care discount. They use pharmacy medication discount. and then basically use their own savings, and the parents pay partial insurance coverage. Only 12% had full insurance coverage. And then there are many other small other ways that patients have been finding the money. So in Israel, where it is covered by the Israeli government, you can see that if it's free, 83% had used obviously this option, and it's much more accessible to those patients. And so I would say in the US, there are definitely an increasing number of states that have incorporated fertility preservation as a mandate. And I think we have still a lot more work to be done in this. So those are kind of the barriers that I see. So there could be sort of multiple barriers, and there are some barriers that we can work on to improve. And so I want to just highlight here the new the ASCO guidelines about fertility preservation and what is the standard of care. Is really, one, address infertility as early as possible before treatment starts. We should refer those who express an interest in fertility preservation or are ambivalent to the reproductive specialists. And the discussion should be early, as this will reduce distress and improves quality of life. So I wanted to briefly touch upon really what's new in fertility preservation. And so here we have ovarian protection modalities, and we have here assisted reproductive technologies. And so this is a really nice slide from this author who basically has everything covered here that is available to patients. So for ovarian protection, GnRH agonists have been used, and we can talk about sort of that this is sort of lower on our treatment options. If the patient is having radiation, we can move the ovaries out of the radiation field. So this is the oophoropexy. So for specifically breast cancer patients, we can do the ovarian stimulation and collect eggs using tamoxifen or aromatase inhibitors to decrease the amount of estrogen exposure. So this kind of lives over here because it's part of kind of egg freezing or embryo freezing. So then most people will know about egg freezing and making, if they have a partner, that we can make embryos and freeze embryos. And then the new kid on the block has really been sort of ovarian tissue retrieval. And so majority of the work has been in here, where there have been many cases of ovarian cortex freezing and sort of auto-transplantation leading to live breasts, and we'll talk a bit more about that shortly. And then the IVM is in vitro maturation of oocytes, so getting really immature eggs and figuring out how we're going to mature them. And so these two are still in the experimental, and all the ones in blue are basically things that we can offer patients now. So, so what ASCO also updated was some recommendations about what type of fertility preservation methods should be used. So as we talked about GnRH agonists, which is leading to ovarian suppression, they should not be used in place of proven fertility preservation methods such as egg freezing or embryo freezing. So that's kind of low on our sort of tools. If we have no other way to help the patient, then yes, we will give them the GnRH agonist. So ovarian tissue cryopreservation and transplantation as of 2018 was still experimental in the US. That is the only method for children, prepubertal children. And we need more safety data for patients with leukemia. But outside the US, it has been deemed non-experimental for a few years already. So the big endorsement really was that the American Society of Reproductive Medicine in 2019 said that ovarian tissue banking was an acceptable fertility preservation technique, and it's no longer considered experimental. So this was a really big impact for the fertility preservation field, because it was no longer deemed experimental. So you no longer have to do an IRB to recruit the patients. And so this is part of standard of care. And that opens up to potentially that maybe insurance companies will cover this type of fertility preservation, especially for the young prepubertal children. And so here we are with sort of how we think about the way that we can work with our oncologists. And so here we have our primary oncology team, and you'll be meeting with Sarah Felderhoff, our Fertility Navigator, and she will really tell you about the nuts and bolts of what we've been doing at DelMed. So it is central to have a fertility navigator who will help coordinate the care of the patient and the family. And so the oncology team, if they have one, will also speak to the fertility navigator. And then the fertility navigator is the main person who will speak with the family, patient and family, to counsel and to offer different fertility preservation options. And then how we view it is that the fertility navigator will work with a psychologist, the social worker, the REI team, which is myself, and then we have Live Strong Fertility, and sort of coordinate sort of how to pay for it. And so really I think that it's really key for the oncology team to work with the fertility preservation team, and that having a fertility navigator is key to this program to really coordinate the care for the patient, because the patient has so many other things, to deal with the cancer treatment, and to really have someone to really coordinate the fertility side of things will help the patient be educated and then go on to sort of the next step of their treatment if they desire that. And sorry. And then we have sort of all the other arms helping the patient here. And then sort of conversations between the patient and the fertility navigator. And then fertility navigator talking to the primary oncology team. So lots of communication. So I thank you for your kind attention. And if you want to email me with questions, I'd be happy to answer those. And thank you again.
Thank you so much, Dr. Mack. We're so grateful that you were able to put that presentation together and share it with us. Our next presenter is Sarah Felderhoff. Ms. Felderhoff specializes in oncofertility and is a licensed advanced practice registered nurse in both women's health, a clinical partnership between UT Health Austin and Ascension Seton, and UT Health Austin's Livestrong Cancer Institutes. She's also part of the Calm Care team and part of UT Health Austin's Cancer Fertility Preservation Care team. She earned her bachelor's in nursing from the University of Texas at Austin and her master's in nursing from the University of Texas Medical Branch. Ms. Felderhoff has a background in women's health, pediatric oncology, and family medicine. She is especially passionate about oncology and truly loves caring for patients of all ages facing a cancer diagnosis. She enjoys working with the patient as well as their family to find the treatment plan that works best for them. Welcome, Ms. Felderhoff.
Thank you. I hope everyone can hear me okay, but as she mentioned, my name is Sarah Felderhoff, and I'm the oncofertility nurse practitioner. I see patients at DelMed for UTHA and Livestrong Cancer Institutes. obviously get tons of referrals from outside oncology practices. And then I am also seeing patients at Dell Children's Medical Center. And I coordinate all aspects of care for our oncofertility patients. And Dr. Mack, talked to you a lot about, the fertility preservation options for our patients currently available, about the barriers to patients receiving oncofertility services. So I wanted to talk to you a little bit about our program and what a visit with me looks like. And just kind of tell you more information about what it looks like to from start to finish with an oncofertility visit. So I don't think I can proceed my slides. So do you mind going to the first slide for me? Perfect. So there is, across all of our organizations, across ASCO, ESMO, and ASRM, the guidelines are clear that all of our patients should be informed of fertility risks, before they start treatment, with us documenting this in their medical record. They recommend that in-depth information be provided to the patients, referrals offered, and also that, we are providing these patients with written as well as online information for the patients. When I see children, a lot of times the parents will help make these decisions. And, most of the time, depending on the age of the child, I will also try and get assent from the child as well. Next slide, please. And just with those recommendations, you can see, it's very important for us to be talking to each patient, and it's, highly recommended throughout, all of the different organizations. As Dr. Mack talked about, there are several barriers, to these services. She talked a little bit about, patients' financial situations. I've seen a lot of oncologists not refer kind of based on, type of insurance, age, and, some providers have just kind of assumed that their patients have completed their families based on number of offspring. So, for our program, my goal has always been to see every patient and offer every patient this service, regardless of age, current offspring, financial situation, type of insurance, because you never know who is interested in fertility preservation. And, I like to empower my families to, build their family as they see fit. So I don't know what they want their family to look like. That's their decision, and I empower them to make that decision. So, our goal, one of our goals of our fertility preservation is to aim to protect, our patients' future fertility that's being threatened by, either a cancer diagnosis or other various diseases. I don't just see only cancer patients. I also see anyone who is getting high-risk treatments that tend to affect infertility. So, some patients with, for example, rheumatic arthritis and lupus are receiving some of these high-risk chemotherapies. And so also these patients need discussions on fertility preservation. So our team bridges oncology and other specialties and reproduction in order to help people explore and expand the options for their reproductive future. And as I said, my goal is to reach out to all patients at risk, regardless of their assumed barriers. Next slide, please. So just to kind of talk about what a patient visit looks like with me. So prior to them beginning treatment, the goal is for the oncologist that is seeing them, or whoever their medical primary provider is to refer almost immediately. So, as they're getting the diagnosis, the referral to oncofertility should be put in that first visit, because this is very time sensitive. And our goal is always to see these patients before they start these high risk therapies. So, as soon as I receive these referrals, I usually reach out to the family personally and help get them scheduled to have an initial consult with me. And I'm happy to always do these consults either virtually or in person, especially with, everything that's going on with the pandemic. A lot of times these patients are more comfortable initially meeting over telehealth, which I think is perfectly fine. Prior to seeing them, I do ask the oncologist to send me their treatment plan, diagnosis, and possible total doses of medication throughout their therapy, so that so I can do a little background work prior to seeing the patient. And part of this background work is calculating a risk score so that I can talk about it with these patients, and that's based on their treatment. So at that first visit, I review in depth their risk score, and I'll show you on a future slide kind of what that looks like. And we talk about based on their diagnosis, based on their therapy that they will be receiving, what is their actual risk to infertility? And then we go from there and talk about the options that Dr. Mack went over with you. And I try and discuss every option in depth. For a lot of patients, every option is not, available. For example, the children that I see, if they're pre-pubertal, it's not possible for us to do egg freezing. So we mainly discuss tissue preservation. But I still try and touch on all pieces of this. I try and give them details. I also try and provide written and online materials, because a lot of these patients just face a cancer diagnosis. So, this is a whole lot of information being thrown at them at once, on top of everything else that they've had to go through with their oncologist and everything else. So, I usually do a virtual visit. I'll provide them with a lot of information. I'll usually try and do a follow-up call the following day, just to touch base and see if they have any questions, as they kind of were able to mull over the information overnight. Once we've done all this and they've kind of mulled over the information, any initial lab work, paperwork, I assist them with consents. I try and help them and walk them through each of these things, because again, they have so much on their plate to start with. Anything that we can take off their plate is helpful for them. I also, at this time, start looking into their insurance and what is the financial burden for them. So what is insurance going to cover? And I try and give them a really good estimate of what are they looking at for out-of-pocket price. Next slide, please. And then, once I've done that, I kind of direct them in the route that they're supposed to go. So either have them see a reproductive endocrinologist. I help them make that appointment. And usually I like them to be seen a day or two after our appointment. If it's a child or someone who doesn't have the time to do an egg preservation but are interested in tissue preservation, I schedule their pre-op appointment and try and get that pretty quickly as well. Also, I will help the patients do any pre-procedure consents, any storage consents that are needed, and then also work on financial assistance programs with them. There are several really great financial assistance programs that are specifically for oncology patients that have been wonderful for my patients. Also insurance has started being better at covering tissue preservation, which is fantastic. But, in Texas, a lot of these services still aren't covered even for oncology patients. So these financial assistance programs are so important to these patients. So I help them, fill out those applications. Some of them are lengthy and they need a piece filled out by the oncologist. So I help coordinate this, get their oncologist to fill all of that information out. And in the meantime, these patients are starting to see either the reproductive endocrinologist or the surgeon to get things going. And then as far as, next steps after that, I just try and coordinate all their care and, be as helpful as I possibly can throughout the process. And then, I try and follow them after they've finished fertility preservation too. Even if the patient chooses not to do fertility preservation, what we do is we continue to monitor their fertility status after they've completed treatment. And, for so many patients, survivorship has become such a, with cancer cure rates increasing and, better treatments coming out, a lot of our patients are surviving cancer and are moving into the survivorship or post-cancer phase. And a big part of that is also fertility, because a lot of patients weren't able to go through fertility preservation. So I also see patients that have already finished treatment, are in survivorship, and just what we kind of do is watch their fertility status. And, you know, there's things that we can do after treatment to still help them build a family the way that they would like to build their family. So I do get a lot of referrals of from patients that have either already started treatment or that are in survivorship, and I still like to see those patients and help them try and build their family, because that's so important to them for life after cancer. I also do all the post-op visits for patients who do the tissue preservation, and continue to follow them throughout survivorship until they feel like they don't need my services anymore. Next slide, please. This is the 2 risk stratifications charts that I mainly use. And basically this just gives you an idea of who is at a minimally increased risk and who is at a high risk. Anyone that's going through a stem cell transplant is very high risk because they're getting total body irradiation and large doses of chemo. So those patients automatically should always see and have a fertility preservation visit with someone who specializes in it. And then, you know, radiation, it depends on the amount of exposure and where the exposure is. So, you know, this is part of my risk calculation too that I do with the family. And then as far as the chemotherapy doses, how I calculate that is I use a cyclophosphamide equivalent dose calculator. And basically this helps us decide how, you know, based on how much chemotherapy they're projected to get, what their risk of infertility will be. And I review that score in depth with the family. Next slide, please. And this is the same thing except for males as well. Next slide, please. And that is basically it. I know we don't have time for questions right now, but I'm happy to answer any questions at the end of the presentation.
We're delighted to welcome Christine Janelle Adley. Christine is an award-winning advocate living on the south side of Chicago. She's devoted to her work as the project coordinator for the YAAS exclamation point grant through Living Beyond Breast Cancer. Paired with her background in comprehensive knowledge in patient advocacy, she is committed to promoting health equity and reducing health disparities in underrepresented communities. She's a public speaker and an aspiring author committed to using her experience to serve as a driving force of change for others. Welcome, Christine.
Thank you so much. I appreciate you. So again, my name is Christine Janelle Adley. I'm the project coordinator for the YAAS grant at UIC, all about creating equitable support for young women with breast cancer. At the age of 23 in 2015, I was diagnosed with breast cancer. At the initial time of my diagnosis, I met with my entire healthcare team, which included my oncologist, genetics, and social works. For the next 2 months of returning to the hospital to get all of my diagnosis, to figure out my stage and type of breast cancer, I returned weekly and was eventually diagnosed with stage 2 triple negative breast cancer. A week before I started treatment, it came to my attention that I needed to see fertility. This was something that no one spoke to me about, even though I already had a pre-existing history with cancer. During that appointment, they shared that I had very limited time for IVF. They shared that it's typically a 7-week process, and with me starting treatment the following week, I had no time to harvest any eggs. They only gave me one option, which was the ovarian tissue extraction, which at that time in 2015, they shared was extremely experimental. And though it has been successful, it wasn't successful in every case. I had an appointment, I had a surgery scheduled 2 days later to have my port implanted as well as my right ovary removed. The more I thought about this treatment option, the more it scared me. At the time, I was 23 years old. I was on disability due to my cancer, and I was living at home with my mother. The idea of the financial constraints really struck a lot of fear in me. They didn't share what the out-of-pocket cost would be as far as after insurance covers. They only showed what the storage fee would be. And since I was on disability, and on a very small income, the storage fee was not conducive for me. So at that time, I decided actually against getting my right ovary removed. I was afraid that if my ovary was removed, that I would be sterile or infertile based off the fact that chemotherapy would be really harsh on my left ovary, and it actually had the less amount of eggs. So due to that, I went against it and decided that I would keep both ovaries. And as a result, the only option that I had for fertility preservation was getting Depo-Lupron and putting my ovaries to sleep. I very much wish today at the age of 29 that my healthcare team set me down at the time of my diagnosis when I was meeting with my entire healthcare team to have me meet with the fertility consult. One, for me to understand the actual damages that the chemotherapy was going to do to my fertility, but two, so that I had enough time to take part and capitalize on all the options that were available for me. If I had met with my doctor at that time, I would have done IVF, especially because I have leishmania, I have TP53. So having eggs that was already harvested that I could pick through to figure out which ones had the gene mutation and which ones did not would have been something that today at age 29 would actually be desirable for me. Now at 29, my body is tired. I have had countless surgeries. I have had countless medications. I walk on a prosthetic leg every day, and my body does not have the energy or the strength or endurance that it did at 23 to go through IVF. And so at this point in my life, my options for children are limited. Again, I cannot stress how bad I wish that they had talked to me about that. Knowing that at the beginning of the time of diagnosis would have given me the right to advocate for myself and choose what option was best for me and not what was left for me. I want all young women who are diagnosed with any cancer, especially breast cancer, to have that opportunity to take charge of their health and make their best decision for themselves. It is of utmost extreme importance for young women and men who are diagnosed with any type of cancer to be given those options at the time of diagnosis so that they can make their best healthcare decision. So that's me. I appreciate you all for listening.
Such a powerful story. Thank you so much for sharing that. Wise words from a wise woman. Thank you so much. Our final presenter today, we're so happy to share with you, is Dr. Lakshmi Balasubramanian, and we all call her Dr. Bala. She's a local oncologist here in our community. Dr. Bala is a hematologist and medical oncologist currently practicing at Texas Oncology in Cedar Park, Texas, by the way. She completed her medical doctorate in Chennai, India, and she received her master's degree in molecular genetics and microbiology from the University of Florida, where she stayed on to complete her internship and residency in internal medicine from the University of Florida, and then finished it off with a fellowship in hematology and medical oncology at Northwestern University in Chicago. Her areas of special interest are breast cancer, women's health, cancer survivorship care, gastrointestinal malignancies, and novel therapeutic agents. Dr. Bala is a published author and has received numerous accolades and is very involved in survivorship community outreach programs. We turn it over to you, Dr. Bala.
Good afternoon, everybody. This is such a pleasure to give this talk to on behalf of Texas Oncology to BCRC. First, want to give a shout out to everybody at BCRC. I've been in Austin for 15 years. Breast cancer is one of my primary fields of practice, much as I do general oncology. And I can't tell you how much BCRC has provided in terms of navigation to our patients. It's just an incredible service that they provide, not just the talks, but the navigation, the support, helping patients understand the whole process, getting them comfortable through the process. So thank you and a shout out to you guys. I was asked to speak on these strategies to reduce implicit bias in cancer survivorship care, and particularly focus on fertility in young women. So I was going to give you kind of, a provider's perspective. We all have our biases, and it takes a lot for us to recognize what our biases are. And it's evolved through time. One of my initial experiences was actually at the VA at Gainesville, Florida, where I was asked to take over a patient from a colleague of mine. And the reason for that, the veteran had been in combat and could not accept the physician who was taking care of him, who was of Eastern Asian origin. He had PTSD and just couldn't do it, so wanted a new doctor. And I showed up and I was like, listen, I'm brown, but I'm also Asian. But the way we look, has a lot to do, the way we present, the way we speak. There are those biases that run in every one of us. There are also many other biases, religious, social, ethnicity, color, several things that actually came to be even more highlighted in terms of diversity last year in 2020. So one of the things, think about, how can, as a provider, I be open-minded? And what struck me a few years ago was, when I say I want to be open-minded, I'm thinking about it from my perspective and not the other person's perspective. So I might want to be inclusive, and I might think about how I want to be inclusive in this, but not really thinking in how the other person would perceive it in inclusivity. And the story we just heard from our YAS survivor is very powerful, because nobody asked her what was important. We just presumed these were the things that were important, and we needed to address it. So next slide. So there's the unconscious social bias. Oops. I think I lost the screen. Okay, give me just a second. Sorry, guys. Okay, yeah, there's the unconscious social bias. So I just put in some, things for us to think about as we go along. Next. There's the obvious emotional, age, race, prior parity, marital status, gender, socioeconomic status, insurance, many things that were already pointed out by Dr. Mack and Ms. Felderhoff. I just recently saw a 36-year-old, and to her, she's ambivalent about her third child, but it is important to her to keep that option open. So I can't presume that just because she's had 2 children, that her third child is not as important as her first or second, or to keep the option is important. And on the flip side, I saw a 30-year-old male with rectal cancer, and it's so easy to sperm preserve, and it costs very little. And the Livestrong Foundation offers 50% support of whatever it costs to do sperm preservation, but he declined. And I asked him at 2 visits, and then I realized I need to stop. That is his decision. Regardless, we've counseled him. I've offered him the choices. And so that bias of, of me thinking, okay, you don't have children, you're a young male, it's easy to sperm preserve. So that unconscious, that implicit bias that I had was playing a role in that. So we need to think about, the other side of somebody not wanting to do it and moving on as well. Next. And as we treat breast cancer, one of the other aspects is the subtype of breast cancer. The inflammatory breast cancers are pretty aggressive, and sometimes we don't have time to go through reproductive fertility preservation. But it's important to address it very early on if there is a possibility at all. Sometimes it does take us a couple of weeks to get a port in, to get their testing done, to start chemotherapy. And now with some of these new fertility preservation methods, besides us using GnRH analogs like Lupron to suppress the ovaries, they can preserve ovarian tissue pretty quickly. So that's one of the first things we need to do so we don't delay treatment nor impact their future ability to have children, because we do and want more of our survivors to have a good quality of life and have no regrets about what choices they made. The next. And the urgency of treatment. So tying these two in, the subtype and the urgency, inflammatory breast cancer is one subtype. The other is the estrogen positive breast cancer subtype, where from the patient's perspective, they have the survival mode and want to get things done. And future fear of recurrence when we say, okay, this is going to get fed by estrogen, there's an estrogen fed tumor, and then we're sending them to a reproductive endocrinologist to take some time to get their fertility preservation done. And we're talking about using drugs that block their estrogen while they're being stimulated to preserve ovaries or eggs or do IVF, somewhat contradictory. And this is where evidence-based medicine comes into play. And I have some slides later to kind of show that it is not unsafe to do this in estrogen positive tumors. Next. And this is the first time I'm doing a presentation on this, so I had to sit and think about what strategies would I need to take to reduce implicit bias, or for anybody to take. So there are self-assessment tests, and Dr. Stone just gave us one. It was quite interesting. It was like a test of neurologic coordination. There's somatin coordination, mental health in coordination going on, trying to get that together. Really nice assessment and recognition of the fact that implicit bias is so important to address. There are a few websites, implicit.harvard.edu and Project Implicit, that have questionnaires we can try, but most of them are aimed not at healthcare providers, but more, race, ethnicity, religion, color, etc., that are taken into consideration, more like workplace bias related questionnaires. So I've over the years started putting in place some checks and balances amongst myself and my team in how to address this. The first thing is ask myself at the first visit, because that's usually a nice time set aside with a long period of time, and ask anybody in the reproductive age group if fertility is something we need to address. Sometimes, yes, it does get missed because somebody's anxious and the initial visit might not go as planned. The next element, at least, is when I do every new patient note, I include something called supportive care, and I have one of the questions when I'm completing my note to say fertility was addressed, and then I can catch it there. So that's part of the NCCN guidelines and ASCO guidelines for us to address fertility preservation, and using it as a supportive care questionnaire along with nausea, vomiting, diarrhea, and no tobacco cessation, just as important to include it in that list. And the next element where it can be included, I've learned, is in chemo teach, when I have our nurse practitioner and nurses doing the chemo teaching. That's another time where it is really important, where we're talking about side effects. So even if we missed it in all of these layers, to educate our staff and during the chemo teach to get that addressed. Next. So what are the limitations to fertility preservation? One is time. I do have to say the time to fertility preservation I have found even in my young women with aggressive tumors like lymphomas, Hodgkin's lymphoma. I had an 18-year-old granted ABBD, had a 10% infertility rate at her age, but it's 1 in 10. And at 18, she does not have the objectivity to see that it was an important thing when she is 29, 30, 40. So her parents, of course, were wonderful. And within 2 weeks, we got her fertility preservation done while we're going through all her testing. The other is financial. I have a separate slide with what Texas has to address. But just a personal story, I personally went through IVF. I did that in Florida when I was a resident, and it was expensive. I'm glad it worked. I have a child, but it was quite a bit of cost. And I moved from Florida to Illinois and realized Florida is not a mandated state, but Illinois is a mandated state. So they will pay for fertility therapy in full in Illinois, like Israel does, but Florida does not. So that financial burden is not something everybody can take on, and financial assistance programs are important there. The social support from the family and their friends, resources that we can provide them or the reproductive endocrinology group can provide them, reassuring that it is safe to do, and addressing the emotional distress of having to go through one more thing when they have so many things going on as they're preparing for treatment. And then there are many state mandates for insurance that we need to take into consideration. Next. So this is our Texas insurance code requirement, and I was actually quite shocked to learn there was something in place in 1987 and again 2003. Because really, they don't pay very well. They're getting a little better, but they don't. But it requires health insurers to offer and make available coverage for services that may arise for in vitro fertilization or infertility therapy, but they need to have infertility for at least 5 years or have specified medical conditions. There's religious exemption. So an institute that's a religious organization or a hospital or a group does not have to offer this. But while they do have this Texas insurance code in Texas, this is Blue Cross Blue Shield, right? The law does not require the insurers to provide the coverage, nor employer is forced to include it in their health plan. So there's a complete disconnect in the insurance code and what actually has to be provided. So this is one of those with fertility, and the second, very obvious disconnect also is hair alopecia from systemic chemotherapy. Cold caps are FDA approved, but insurances do not have to pay for it and do not pay for it. So that is another obvious bias from the insurance side where a medically necessary treatment causes a condition. It's something that is distressing to the individual, but it's not covered, although it is FDA approved. So these are all some of the biases from the financial and the insurance side as we are treating breast cancer or any chemotherapy. Next. These are the NCCN recommendations. We've seen some of the ASCO and other recommendations there. Similar, we need to discuss fertility implications before and after treatment, contraception after treatment, the specific methods of how to preserve, and what can we do to suppress menstruation. And the last bullet point is actually something that's fairly easy to implement. So what I usually do is, besides making a referral to fertility therapist, I also simultaneously start getting insurance authorization for ovarian suppression GnRH analogs like Leuperon, because we need to start that before chemotherapy. We need to shut their ovaries down just before they start chemotherapy and keep it suppressed through. That's also part of many of our breast cancer treatments in estrogen positive tumors. So it's pretty easy to start and continue thereafter, but we do need to address the fertility before we start this. Next. So there is a trial that is ongoing. This is a trial that Dr. Ann Patridge, who's a huge advocate for women under 40 at Dana-Farber, and Dr. Olivia Pagani. So it's an international trial that's ongoing. And one of the important purpose of this is there are many delays in childbearing, especially in young women. They have to make decisions before completion of their reproductive plans. And infertility has a significant, as we saw in one of the trials that was presented by Dr. Mack, I think it was the UCSF study that suggested regret and quality of life is a substantial long-term distress in young women with breast cancer. And we need to give them the options for infertility, that will influence their treatment decision. There is data, and I will show a little bit of that too if we have time, that suggests that pregnancy after breast cancer does not increase a woman's risk for developing a recurrence. Next. So this trial is looking at women who are desiring pregnancy, and the age groups are up to age 42. And there are studies that show that birth outcome is not different than normal population. There are some risks of delivery complications like more C-section, preterm birth, low birth weight, but that does not impact a child's health or the long-term outcome. So there are some things that are taken into account with this positive trial, and it's an elegant study. The study is structured such that the estrogen positive breast cancers, women with estrogen positive breast cancers on tamoxifen or hormone blocking therapy will get to about 18 to 30 months into their treatment, hold their treatment at that point, wait 3 months after they interrupt because tamoxifen has potential birth defects, and then attempt contraception, pregnancy, breastfeeding for 6 months, and restart. Next slide. So this is it's an intervention study. The idea is to include 500 women. When the study was presented at our 2018 ASCO, and then later updated at San Antonio in 2018, there were quite a few women who were already enrolled in the study. It started in 2014, it'll end of next year, but there's a 10-year follow-up and then an updated 14 years. So we won't get the final results until 2028. Next slide. And this is what I said, with 3 months washout, pregnancy, and so total interruption of up to 2 years. Next. There's a lot of secondary outcomes that are also going to be looked at in this, that includes the distant recurrence-free interval and what kind of assisted, that's reflective, it's reproductive technology, breastfeeding patterns, several secondary outcomes that are going to be looked at with this. Next. And these were some of the presentations, but at the end of 2018, there were 339 women with estrogen positive tumors that were recruited in 20 countries, and 57 healthy babies had already been born as part of this trial. Women will be followed for 10 years. So I share this ongoing trial with my patients as I talk to them about fertility therapy, because it may be relevant to them if there are updates in the next 2 or 3 years. Next. The other study, this is actually a meta-analysis, so a bunch of different studies, retrospective data that was looked at, that was presented last year, San Antonio 2020. And this was looking at the safety of becoming pregnant after breast cancer treatment, safety of the mothers and their children, and what are the chances of becoming pregnant, what are the risks of pregnancy complications, and does it affect cancer recurrence and survival? Next. And the outcome was the women who had breast cancer treatment, there were several similar characteristics between those who had breast cancer treatment and who didn't. Pregnancy-related complications were not much different. Some of the things we saw were C-section was slightly increased, preterm delivery was a little increased, etc. And there were fewer pregnancies, 60% fewer pregnancies. But it was unclear if these pregnancies were because of choice to attempt a pregnancy after what they went through with breast cancer treatment, or if they had difficulty in becoming pregnant. We couldn't tell because this is a pooling of many, many studies. Next. And the strength of this was there were about 7,500 pregnancies after diagnosis. You can see how many records were included. General populations was compared to, there were about 112,000 patients with breast cancer, of which 7,500 had pregnancy after diagnosis. So it had a strength in numbers. And there were also a variety of patients with node positive disease, hormone receptor positive, BRCA mutation positive, etc. Next. There were limitations. It did not look specifically at the outcome of women with BRCA mutations. The fertility treatments used wasn't looked at, and then there was no subgroup analysis of ethnicity and race and such, that if there was any barriers over there. Next, please. Sorry, we'll go back one more. The results showed that there was no increase in rate of cancer recurrence in women who had a history of breast cancer and had pregnancy and delivery after. So this was very, very reassuring that this many number of patients were looked at across the board, across many countries, and we had a very consistent report that came out of this. The overall survival rate, and this has to be taken with a grain of salt. We can't tell women to get pregnant after this because the survival is better, but it did not affect their survival, but it suggested that there might be an overall survival rate in those women. In BRCA mutations, the survival was also a little bit better, and the results were true regardless of node positive or hormone receptor positive status. Next. So the conclusion was that these results provide reassuring evidence of the feasibility and safety of conceiving in women with prior history of breast cancer. So I think this is a really important, elegant, and reassuring study for oncologists as we make, because from our side, we see people recur, and our fear is we don't want to hurt them in the process of giving them advice. But this should be reassuring to us to make sure we refer all men and women of reproductive age group, regardless if it's breast cancer and it's hormone driven, and particularly if it's somebody with breast cancer who will be on endocrine therapy for 5 or more years, that there is a way for them to consider reproductive decision making as part of their treatment planning. Next. And here are some of these references. So thank you.
Thank you so much, Dr. Bala. That was really informative and really interesting. I'm going to hand it over to Lauren to finish out our event today. Thank you, Lauren.
Yeah, thank you, Rayanne. And I want to invite everyone who presented to come back onto video. We're going to try to pin everybody's videos, but at the very least, we will all be able to speak. And so we're going to go into our Q&A session. We have gotten a few questions in the chat in the Q&A box, but I want to invite you, if you have any more questions or if any arise while we're going through the Q&A, feel welcome to go ahead and continue to ask questions because we do have some time. I want to start with Dr. Stone. I want to give you a few minutes to be able to address the question that came through earlier from Sue, and I'll go ahead and read it out loud. So it says, for those of us who are advocates, are there suggestions we can give patients to help them spot and counteract when they are feeling implicit bias from their providers? So I just wanted to, I know you answered in the Q&A, but I wanted to give you a chance to answer that live as well.
Yeah, so I think that there's a number of strategies that the research suggests can be effective for reducing implicit bias, not only for ourselves, but also for others. And with respect to that particular circumstance where a patient is feeling like a doctor, a physician, or a nurse perhaps is expressing implicit bias toward them, is there something they can do to confront that? The research on confrontation, and we've written a chapter, which is what I shared in the Q&A. I'm thinking I should share it here in the chat so anybody can get a hold of it. I'll just paste it in here real quick. What we talk about in this chapter, which is in a great book, by the way, that's a review of all the literature on the effectiveness of confronting prejudice. Like when can you do that effectively? When do you do that it blows up on you, makes things worse? Quite a few chapters in there. Ours focuses on specifically confrontation as a tool for self-advocacy for not only for patients, but for providers as well. And the thing to know about confrontation is that what the research suggests is that there's some good steps to use to make sure it's effective. And the first is when confronting somebody about their own biases, you can expect them to be defensive right away. And part of that is, very few people really think they're biased. And so when you point out that they're doing it, and maybe they're doing it in a subtle way, or maybe they did it through a microaggression, they're oftentimes not aware of what they've just done. And so you're calling attention to it in a way that is going to make them feel like you're saying something that's not true about them, that they're a biased individual. And so you have to anticipate that that's going to be their first reaction. So the first thing to do is to, find a way to reduce their defensiveness. And, you can do things like focus on the behavior, not on the person. So talk about, what the actual action was that conveyed bias, rather than saying, hey, you're a prejudiced person. And it does help to, if you can really sit down and talk with somebody, talk about, for example, hey, you're a really great provider for me. I really appreciate everything you do, but there's one thing I need to ask you about. So you're kind of using what we call a compliment sandwich, right? Where it's like, hey, I want you to know I really value you, but there's one thing we've got to get into here. And that giving them the positive feedback first kind of reduces their defensiveness so that they're more open-minded to what could be coming next. That's a common thing that, people use a lot. Sometimes it's good to question their intent. Did you mean what I think I heard you say? And that can open up, the door for them to go through some self-discovery. It can help to talk about the consequences it had for you, for the patient, to talk about, this really hurt me, or this really confused me. I assume our relationship is one where you're trying to be equitable, you're trying to provide the best care you can. And then, to the degree they're expressing stereotypes that are inaccurate about your group or you want to be able to question that. You want to be able to challenge that assertion. And then there's a number of strategies that are in my slides in a little bit more detail. Things like that reduce implicit bias kind of right away. Things like drawing attention to things you share in common with somebody can, put us all on the same team, and that can reduce implicit bias. It can help to really point out how, either the person they're perceiving or maybe yourself is opposite of the stereotypes that they are assuming are true about you or a person that they're talking about. In other words, challenge the accuracy of these beliefs that we know are wrong. And I think I can't remember who it was in the speakers talked about perspective taking. That's a really, really important strategy for allowing somebody to really put themselves in someone else's shoes or in our shoes so that they really understand what we're going through. And so those are a variety of different strategies that can work. But, I've always thought that it'd be great to be able to provide education in this for patients. I don't know of any work that's really seriously done that. And so we don't know how much of, what we need to do to make it work. We don't know what, what kinds of workshops we have to create or educational materials, but it's definitely something I think, while we're teaching these strategies to providers, we should be also, I think, providing them for patients as well. The question is, what's the best mechanism for that? Hope that was helpful. I know it was a lot of info.
Yeah, it was a lot of info. I know we could spend not just another hour, but another week, if not more, talking about this.
Yep.
And I thank you, Dr. Stone, for expanding on that. Christine, I saw you nodding your head a lot. So I'm assuming a lot of that really resonated with you. And as the survivor voice in today's panel, I wanted to give you an opportunity to say which of those strategies really resonated with you. I don't know if you've tried any of them or if there are any that you would recommend to other patients to try that have gone through your experience.
Yeah, so I appreciate listening to Dr. Stone's presentation. I myself found it extremely enlightening and got the opportunity to just learn a lot, especially on just being able to advocate for myself. As far as which of these are the best, I think depending on the light, all of them could be conducive for the person. It's just figuring out which is best for their mode of communication. But I actually had texted my boss like, yo, this is really amazing. We should, speak about this, because I think a lot of places, whether it's in the community or the medical profession or even internalized, has a lot of implicit biases throughout your day-to-day, regardless of your survivorship status or just being out in life. So I just really appreciated really listening to his presentation. I myself learned so much that I'm going to implement throughout my life.
Good.
Yeah, absolutely. I echo that. It was really informative for me. I wanted to ask Sarah, I know that you are part of the Livestrong Cancer Institute's COM clinic, and I know that's a really innovative new model. I've heard a lot about it through colleagues that I know who work there. I was wondering if there have been any organizational efforts for the care team that works in the COM clinic to reduce implicit bias, or how you think just the COM clinic model in general reduces implicit bias. And I can link to the Dell Medical School webpage that talks about that for people who don't know about it. But I just would love for you to expand on that.
Sure. So, we've done a few trainings on implicit bias. So I think that's been really helpful for all of us. And that's kind of been institution-wise at UT. And I think it's been, really great. I also think the CALM model, which is basically where we provide all of these services within one clinic. I think because we're all already there and so close-knit and we have all these services inside of our clinic, it allows the providers to be able to directly communicate to one another. And it also, so I can tell all of the providers I work with, hey, I want to see every patient. So they now know, like, I want to see every patient. Whereas when you're referring to outside centers and you don't have all those services included, sometimes communication gets a little disconnected, and a lot of times it leaves the patient feeling like, are my providers even talking to each other? Are they, listening to me? Those type of things. So I think just the fact that we're all there and trying to provide all these services and work as a unit helps reduce some of that.
Thank you, Sarah.
Yeah.
Dr. Bala, I wanted to ask you, this is a little bit more, not as much as about implicit bias, is just wondering about the new oncofertility recommendations, or I don't know if they're new, but how can a patient's medical team work together to ensure that the NCCN oncofertility recommendations are being properly and successfully implemented?
I think the first step to that is recognition, right? That we need to discuss that with the patient. We get so wrapped up in talking about cancer and its treatment that we forget that we need to start the conversation with survivorship along with what are we going to do about your cancer? Because the survivorship part of it takes more time than treatment planning. It's not as quick as to get a port in as it is to preserve fertility. Takes much longer. So I think the first step is recognition, and then education. So whether it's with the provider or the staff or our supporting team, the nurse practitioners, or social worker, I mean, there are so many elements of our team who touch the patient. There should be some way where we should be able to capture all of those elements.
Thank you so much. That was really helpful. We have maybe 2 more minutes. We have a quick closing, but we have a few more minutes, and I wanted to give each of you an opportunity. I really like to have tangible takeaways and action items anytime I attend a continuing education session or event. And so I'm assuming some of the people in the audience are the same. And I know we've talked about a lot of those already, but there's been a lot of strategies and takeaways. I wanted to give each of you the opportunity to share, like, if there was one quick takeaway or one action step, if people want to leave today and say, I know this is something I need to work on, and I would think all of us do, right? What's one thing I can go and do today to start addressing my own implicit bias? I'd love to give each of you a chance to respond, starting with Dr. Stone.
I think the big one, again, coming from the research for me is that most of the time implicit bias gets communicated non-verbally. And so what I think is good to take away from this is the idea that when you're communicating with patients or you're communicating with each other, staff, that you really are going to be consciously focused on what you're saying as the mechanism for providing equity, and you don't want to forget that there's another channel of communication going on at the same time. And so your goal needs to be, line up your nonverbals to be as positive as your verbals are, right? Because you're so focused on saying all the right things, you got to make sure that you say it in the way that's positive as well.
Great, I love that one, nonverbal. All right, we'll go to Sarah next.
Sure. So, I think the biggest thing I want to take away is, I thought, Christine, I thought your presentation and just seeing the patient side of everything was extremely helpful. And, I think I just want to take away, I feel like I assume that, oncologists know to offer fertility preservation. And, I would just like to take away that, there's so much room for me to provide education to oncologists so that they're able to offer these resources, because a lot of providers don't know the resources that are available for these patients. They don't know that I'm here. So I think just the take home is not just assuming that these physicians know their resources, and just making sure that I'm getting out there more in the community and making sure people are aware that I'm here. So thank you, Christine.
Yeah, absolutely. Thank you, Sarah. Christine, is there one action item, tangible takeaway you want to share?
Yes, absolutely. I want to say this again. I really enjoyed Dr. Stone's presentation. So it is just making sure that I am intentional in every space, and making sure that I am checking my own implicit bias, whether it's towards myself or the community or others, just making sure that I am very intentional and making sure that my thoughts do align with my actions as well. So again, Dr. Stone, I really enjoyed your presentation.
And Dr. Bala, I'll end that with you.
Let me maybe address it from a different manner. If we, like physicians, I'm speaking from physicians' perspective, have the opportunity to be involved in organizations like BCRC to make aware that implicit bias exists and that we need to address it. So we don't talk about it. And when we talk about bias, we're talking about ethnicity and color, but not medical implicit bias. So I think it's extremely important for us to self-recognize, but also to promote that cause. If we have an opportunity to be on a board or be involved with an organization, to educate the staff of that organization, because a lot of these can be addressed through support groups as well. And how to talk to, how do we reach patients to help them talk to their providers, or how do we address the providers to talk to their patients? So.
Excellent way to end. I thank all of you for sharing your expertise and your time with us today. It's been so enlightening, and I certainly have thought of a lot of things we can do as a program and I can do as an individual to address this issue. Thank you so much for joining us. Again, thank you to the presenters for your time and expertise, and thank you to Breast Cancer Resource Center for being such a wonderful partner. I hope everyone enjoyed today's forum, and we hope to be back soon with more education for everyone. Thank you so much, and I hope you all have a good day.